Sir, we are live now.
Okay, thank you, Rishi. Good evening, everybody, and welcome to today's webinar. Sorry for the slight delay in start because of some technical issues. Today we have our spine surgeon, Dr. Gautam Prasad, who's going to talk to us about spondylolisthesis, which is another very important area of interest, even for your exams from the spine point of view. So I think without much ado, we'll hand it over to Gautam to give his talk. Over to you, Gautam.
Good evening, everyone. Spondylolisthesis is a very important topic, not only for clinical exam, but also for your clinical practice as well. So today, we'll be going through what is actually spondylolisthesis, what do we mean by it, what are the radiological and clinical parameters, and what are the symptoms. How do actually we approach this case based on symptoms, the clinical signs, and what are the indications when to operate, when not to operate, and what are the controversies surrounding these. So let's begin that. So as you can see in the very first picture on the left side, so this area where the yellow mark is, this is the area of the pars. So pars is the area which connects the lower facet to the upper facets through the lamina. And if you get a break in this, it is called a spondylolysis. The moment, because of the break, there is a slip anteriorly, it's called a spondylolisthesis. Now, this is a normal mechanism of any spinal segment in which the lower vertebrae, the spinous, the superior articular process of the lower vertebrae, they hold together the upper vertebrae's inferior facets. And that's how they lock into each other. So this is actually the hook and the catch mechanism. And if there is a break in this, then that's the time that the upper vertebra slides over the lower vertebra, and we call it as a spondylolisthesis. Now, these are the various classifications that we, once we classify the spondylolisthesis, it can be either congenital, in which there is dysplastic abnormality. It can be ischemic, in which there is a defect in the pars. It can be a lytic, or it can be a healed fracture of the pars, or it can be high energy trauma, which led to fracture of the pars. The next category, type 3, is degenerative, in which there is segmental instability. There might be a traumatic spondylolisthesis, in which the fracture of the facet occurs. Remember, this is slightly different from the ischemic type, traumatic, in which we see the type 2C, because in type 2C, there's a fracture of the pars. Whereas in type 4, traumatic, there's a fracture of the hook par. So apart from pars, if there's another fracture of the facet joints, and that leads to listhesis, it's classified as traumatic spondylolisthesis. The next category is pathological, and the last one is iatrogenic. So if you are not careful while doing the laminectomy, that's the time we come across as a iatrogenic spondylolisthesis over a period of time in the post-op period. Once we know that patient is having spondylolisthesis, then we should also be aware of the natural history, because all these patients don't need surgical intervention. So there is some genetic predisposition, as 15 to 70% of these patients, they are in the first degree relatives. Lysis is more common in boys, though the listhesis is more seen in girls. Eskimos are more common to have pars defect. Now, when we say about listhesis, so all those patients who have got lysis need not have a listhesis. It's almost 15% of the patient who have this listhesis, and it increases during the growth spurt. Minimal changes occurs after the growth stops. So after teenage, there is less progression of this listhesis, and pain may or may not be related directly to the progression. Most of the times, these are asymptomatic patients who incidentally have this X-ray finding. If it's diagnosed or noticed for the first time after 20 years, most of the times these patients, they are less symptomatic and they hardly progress enough to need a surgical intervention in their life. Also, there is a some misconception that higher activity, athletic activity, that leads to progression. Now, there are various cases. Even I have a couple of my patients who have grade 2 lytic at the age of 12, and they have been very much active into athletic sports activity. So the risk factors which leads to progression of the lysis are first notice if between 9 to 15 years, girls are more prone to have lysis if back pain is significantly present at the time of diagnosis, and those patients who have postural or gait abnormality along with lysis finding. Radiologically, type 1 dysplastic or the vertical sacrum, or is the slip is more than 50%, or the slip in which the slip angle goes on increasing. These are the one which progresses, they become more symptomatic, and they are more prone to have surgical instability, surgical indications for their instability. Now, basically, the problem which occurs because of lysis are, one is the instability, which we all appreciate. Then the other thing is the stenosis of the exiting route. And in rare cases, there will be stenosis of the central canal as well. So all this leads to the back pain, the leg pain. There might be numbness in the legs or the tingling sensation. The patient will complain of claudication or extension catch, and rarely there will be neurological involvement. Now, the back pain usually occurs because of the chronic spasms, or there is an annular tear or root traction which is seen. Now, in leg pain, if we the main cause of the leg pain is the compression. So, if we appreciate this keyhole sign at the L3, L4, L3, 4, 4, 5, you see this nerve sheet, nerve root coming out, and it's surrounded by the fat pad. But at L5, S1 level, the fat pad is obliterated. There is significant narrowing of the foramen, and that's where the nerve root is getting compressed. So this compression, mechanical compression, plus abnormal mobility, the facetal arthrosis, these lead to leg symptoms. And in clinically, once the symptoms are there, then we need to assess the severity and what all the activities of daily living are getting restricted. Also, one has to check for the alignment of the spine, the gait, how is the patient standing, how is the overall spine alignment, whether the knee and hips are getting reflexly flexed. Now, this is something which is a very important step. Like we always appreciate if there is significant lysis, clinically we appreciate a step. So if we see on the left side, the degenerative lysis, the step is at L4-5 and the lysis is at L4-5 itself. Same picture, you get a step at L4-5 on the right side, but here if you notice, the lysis is at L5 S1 vertebrae. Why? Because in lytic lysis, only the body goes forward. The posterior element is still palpable posteriorly. So here, the step, though it is at L4-5, the lytic lysis, if present, the lysis will be at L5 S1. And if it happens to be degenerative, the step is at L4-5 and the lysis is as L4-5 itself. I hope I am clear with this. So what all we need to do is X-ray, MRI, CT, and then grade the lysis, Meyerding grades or Tillard's grading, and by this, then we calculate what is the. Sorry, so you divide the sacrum part into 4 parts, and depending on the whether it is the lysis is in the first 25%, that is grade 1, between 25 and 50, grade 2, more than 50, grade 3, more than 75, 4, and beyond that, it is grade 5 lysis. Similarly, it happens, and one more important thing is the slip angle. So rather than translation, the slip angle is of more importance, because when we take into consideration the angle of the L5 vertebra, which it makes with the tangent at sacrum, that determines how the whole spine is going to balance over the pelvis. And once we take into consideration all the other parameters of the pelvis, the pelvic incidence, the tilt, and the sacral slope, then we determine the whole whether the spine is balanced or not. So if the spine is balanced, less likely the patient is going to have pain. If the spine is not balanced, more likely the patient will be symptomatic, and more likely that the patient will come to you for a surgical intervention. So this pelvic incidence is of utmost importance. The few things which we need to know is the pelvic incidence, and the mid-sagittal axis as with reference to the L1 vertebra, how it is placed with the S1. So if the L1 axis and S1 axis, if it's more than 35 millimeter, and we end up with an in situ fusion, very likely the patient will be having residual back pain. But if you reduce the same thing by putting a cage or doing a reduction maneuver, then the same patient is going to have a lesser residual back pain. So the point is, if you decrease the distance of the L1 with respect to S1, automatically the chances of the post-operative residual pain, post-operative residual difficulty, that reduces. So in any case, we start with non-operative treatment. So these are meant for people who are actually not very symptomatic, whose pain is not getting aggravated, and who are not very much symptomatic to begin with, no neurological symptoms at the presentation. So for this, we should stop the aggravating factors, try to strengthen the back muscles, and for a period of time, for when the patient is in pain, bracing is advised. And said steroid injections or other management which needs to be done. But as is true with every other things, we need to have a tailor-made approach for each and every condition. So what are the indications for spine surgical intervention? Severe back pain, leg pain, failed conservative trial, patients with abnormal neurology, or those who have positive injections that by giving injection they improve, and after that again they deteriorate. The surgical goal should be decompression of the foramen, address the spinal instability, and also address the spinal alignment. When we come into, once we make the decision, two parameters which are of utmost importance is to what is to be seen is what kind of listhesis is it, whether it is degenerative or spondylolytic listhesis, and the grade of listhesis, whether it is low grade, that is grade 1 and 2, or it is high grade, grade 3 and 4. So the goal of any surgery for listhesis is to provide stability, one. Second, neural decompression if it is present. Third, better sagittal alignment. And we have to achieve fusion so that we prevent further deterioration of the listhesis. Now, when we come to this, there are many controversies, whether to decompress or not, what are the types of fusion, whether we should reduce or not, and whether to do open or minimal invasive. We'll see these one by one. So is decompression necessary? So by achieving a normal alignment, even if we put a cage and we jack up the space, there is no need for direct decompression. So decompression is needed only if there is a significant compression to begin with. Otherwise, we can just rely on indirect decompression, which we can achieve by jacking up the space, disk space with a cage, and reducing the listhesis. So if there's a neurological deficit, significant claudication, or compression of the nerve roots, or central canal stenosis, these are the one in which we do decompression. The other thing is fusion techniques, whether to fuse or not. So Denesis is a non-fusion technique which was in practice some time back, but now there are too many complications, so that's not being propagated nowadays. No fusion techniques. Now, depending on your approach, whether you approach from front, you can have a direct anterior lumbar interbody fusion, or when you approach from sides, you can have a lateral interbody fusion. So depending on whether it is oblique approach, it is as Oref, or it is an extreme lateral or lateral lumbar interbody fusion when you go psoas. So suppose we go between the psoas and the anterior vessels, it is an oblique approach. So that is called as Oref. When we go from posterior and we go by the interlaminar space by doing a laminectomy, it is a posterior lateral lumbar interbody fusion. But if we remove the part of the facet and then do the interbody fusion, it's called as transforaminal lumbar interbody fusion, that is TLIF. So why these things are needed? So as has been shown in this diagram, in this picture, so this is the upper picture shows that this is a segment, spinal segment, in which the disc space is totally obliterated. the neuroforamen is also compressed, and there is a listhesis. So suppose we put in a cage anteriorly, as is shown in the lower figure. So this space gets jacked up. The neural foramen, if you can appreciate, it increases in size. And when we put in cage over here and put posteriorly the pedicle screws, then what we do, we jack up this space. So this is a load bearing area where the fusion mass will be present. Secondly, posteriorly, when we put the screws and fix it in compression, there is a tension band effect phenomena which is happening. So that further helps in fusion, and it decreases the chances of progression of the slip post fixation. So all by doing this, jacking up the space, what we achieve is not only we make the disc space clear to achieve reduction, we also do decompression of the neural canal on the sides as well as the centrally. So once we do this, if there is no significant canal stenosis, we can very well rely on this indirect decompression, and there are many cases to support this indirect decompression, which suffices. We did not do full laminectomy or full decompression centrally. Posterolateral fusion. So suppose we don't do interbody fusion, and before the interbody fusion came in practice, posterolateral fusion was what was being advocated. So if there is a small degree of slip, these kind of posterolateral fusion will suffice. But the rate of fusion is very less, especially because if there is a dysplastic vertebrae, then even the transverse processes are smaller. The chances of disc fusion, the interbody, the inter segmental fusion decreases, because we don't check out the disc. We don't do anything at the disc level. The chances of persistent lower back pain because of discogenic reasons, that will also persist, and there is a chance that this posterolateral fusion, by the time it fuses, there can be progression of the slip. So overall, in lytic listhesis, posterolateral fusion should be avoided as far as possible. And ALF, anterior lumbar interbody fusion. So these are the procedure in which a direct trans-abdominal approach is taken. So once we take a modified financial approach from front, we elevate all the periosteum, all the peritoneum, and we approach the L4, L5 level, and there we do a anterior interbody fusion. Now the risk involved in this is, one, peritoneal injury. Second, because there are plexus over here, there is a very likely chance of retrograde ejaculation in male, which is being seen. Third, there can be a vascular injury while doing LF. So if the complications are less, and many times to start with, we may need an approach surgeon. But if the complication occurs, there can be a catastrophe in such cases. To increase the safety and decrease the dependency on approach surgeon, then came the lateral approach, in which first it was advocated to go from trans-psoas. So that was the extreme lateral lumbar interbody fusion. So by doing this, there was good visualization, good anterior bone end plate which was seen, and because there was good end plate which was seen, a good bigger graft, a good bigger cage, which helps in better fusion, that could be used. But the problem with this was in X-leaf, because we are going through the psoas muscles, we needed to have good neuro monitoring in place. Even after that, there was a good chance of patient having neurological deficit. The psoas hematoma might lead to numbness in the thigh in post-operative period. Hence, it was further modified, and then the approach became Oref. So in Oref, one used to go through the same trans-abdominal approach, retroperitoneal approach, but we used to end up between the psoas and the vessels. So once we end up between the psoas and the vessels, we are not going to touch the psoas. So there was no need for neurological monitoring. There was lesser risk of hematoma in the muscles, and it was relatively safer, and the same thing we could achieve. So this is how Oref was done. Now, whether to do a TLIF, PLIF, OLIF, or ELIF, It all depends on what the condition is, how is the training of the surgeon, and how is the paying capacity, because this olive cage are actually expensive. Whatever is being done, the goal should be a good fusion in the interdisc space and supplement it with pedicle fixation posteriorly. So where after doing this complete anterior as well as posteriorly fusion, which we do, there's a good chance that radiologically the correction will be better, the fusion will be higher, and the patient will symptomatically much better. And next comes the question whether to reduce or not reduce. So in cases in which the slip is very high, okay, and we don't end up reducing the slip, the chance of progression of the slip, the chance of residual pain, that increases. However, should reduction be done in all the cases? Well, it's not so. So if the sagittal balance is acceptable, then the spinal deformity can be instrumented in the stable condition without the need of attempting a reduction. Like this, in this case, in which a stable construct was achieved by doing it transsacral delta fixation, in which directly from sacrum L5 vertebra was instrumented. So there are paper in which there whether to do fixation or not, there are debatable. The surgical management of this high grade listhesis, it's actually debatable, because in high grade listhesis grade 3 and 4, because the spine has been in the same position for a long time, the chances of while attempting a reduction, there can be neurological injury, there can be stretching of the nerve roots, and it can end up in neuropraxia or at times even permanent damage. So whether in high grade listhesis one should attempt reduction or not, that's a big question. So in such cases, what is advocated is reduce as much as possible. Don't aim for complete reduction. Achieve whatever reduction you can, and fix it. The main important thing, as if we compare the translation to the slip angle, it's the reduction in the slip angle, in the reduction in the kyphosis at alpha S1 level, which is more important than the reduction in the slip or the percentage of the slip. So there are various studies which supports that partial reduction is much better than attempting reduction at the cost of neurological complications. So reduction should be considered. There is evidence that segmental instability is there or the sagittal imbalance persists, then reduction should be done. By reducing, what are the advantages? So it improves the biomechanical orientation. It also causes decompression of the neural structures. It corrects the lumbosacral kyphosis and also restores the sagittal alignment. So whenever there is a lytic listhesis, try to reduce by putting it in cage interbody fusion of any sort, and achieve as much as you can achieve without causing too much of strain on the nerve tissue. In situ fixation, what are the things which goes against in situ fixation? The pseudo orthosis rate is very high. It is usually whenever we do in situ fusion, the chances of the slip being persisting over there is there. So it's always recommended that you add up segments higher up, so proximally. So if it's by doing this, we end up using one normal motion segment. So that's a bit very big negative point of having an in situ fixation. And even after this, there is some chance of progression of all the parameters of deformity after in situ fixation. Spondyloptosis, the high grade one. So these are the same thing in which reduction or no reduction, there's bit of confusion, and there is actually possibility of literature which supports or goes against reduction in such cases. Now, what are the complications? Complication can be because of nerve root handling. It can be neuro deficit in one of the foot or both, or it can be caudate venous syndrome. There can be post-operative pain, which might be persistent because of pseudoorthosis or ASD adjacent segment degeneration. There might be persistent nerve root compression or instrumentation irritation. The patient may continue to have flat back syndrome or a low-grade infection or a discogenic pain. So all these things can lead to persistent pain in post-operative period. Overall, as is true with other elderly, age group over 65, presence of more than 2 comorbidities, these are the patients who are more likelihood of having post-operative complication like infection, cirrhosis, and that's true even for lysis patient. Another important complication is ASD. So that's the degeneration of the segment above the fusion level. Here, these are few cases of mine in which I would like to show you how the lysis is there. So this we did an open reduction, and because there was no significant compression of the neural structure to begin with, it was just jacking up this disc space with the cage, and no central decompression was done. This was quite early in my practice. So here I ended up fusing in normal motion segments. So it all depends. This was an obese lady. So as I told you, so previously during my because the learning curve is a bit high, I ended up in this obese lady fusing a non-culprit or a normal motion segment. So all these things has to be taken into consideration when you take in a decision. This is another patient. He has a very high grade lysis. Now we check out, this is almost grade 3 to 4 lysis, and he had very significant neurological symptoms. Now this, we could achieve a good amount of reduction and this patient, and this is at 3 months that he is able to bend properly. Transsacral fixation or another kind of cage, that is banana cage, can be done. Or a fibula graft can be used by jacking up the space. We could achieve a 360-degree fusion in this case. And also one important factor is when we try to achieve a reduction in such patients in which the patient has been bedridden or an elderly lady, there is very likely that post-operative the patient might have a sacral insufficiency fracture. So in such cases, always try to check out the level of osteoporosis, and in such cases, if the osteoporosis is there, we need to add up more segments, slow down also, and have pelvic fixation as well in such cases. So that was from my end, Janki.
Okay, thank you very much, Gautam. We'll take questions now.
Yes, sir.
Yes, sir.
So, while we are waiting for questions, sir, you have explained what if it is and there is sagittal instability, then we can go for surgery. So, sir, is it like listhesis? It can be stable also, sir, when we are.
No, sagittal, I said there is sagittal instability, means that is symptomatic sagittal instability. So patient is unstable, and hence there is significant back pain, discogenic pain, which leads the patient to surgery. Only sagittal thing with a normal neurology, with a normal back pain, I would still tend to avoid surgery in such cases because the patient is asymptomatic.
Okay, sir. So even if it is unstable but asymptomatic, then no need for surgery. Conservative treatment can be
Yeah, you'll
an
be
option.
surprised at the number of, so if you see some of the circus trapeze artists, etc., they'll have spondylolisthesis at various levels, but they are perfectly okay. They have no problem. So I think you have to sort of correlate it with the symptoms before you think of surgical treatment.
So recently I had operated just 2 weeks, just 10 days back, we have operated one patient who had a significant lytic lysis at L5S1. But the reason she came to us was a right leg pain, which was because of L4-5 inferiorly migrated right-sided disc. Till that time, she was totally asymptomatic for that lytic lysis. So here also we attended that only the disc by MIS technique. We didn't do anything for the lysis. And post-operatively, she was fine. She was walking on day 2. So everything went on well. So the point is, lytic lysis is more of a radiological finding. Unless and until it is symptomatic, significant enough symptoms to intervene, don't touch it. There's no need to touch it, actually.
The Sachin has asked about which X-ray view are taken other than AP and lateral for diagnosing it.
Oh,
So the
For
most
diagnosis
important
of
thing is, yeah.
oblique.
So that Scottish dog sign that's there, you take those oblique views. But in lysis, I feel AP and lateral views is alone to it suffice, because in AP, just under the pedicle, you see that lytic thing going around, the pars defect you see. So that's more important. Secondly, if it's a good squared vertebrae on the lateral view, you will be able to see a lysis. And next, what additional view apart from this I would like to have is standing X-ray and the X-ray inflection and extension. Rather than going for the oblique views, I will go for this, because on flexion extension, you put a dynamic thing to it. On and standing, again, you load the spine. So these X-rays, AP in any position, lateral in standing, plus lateral inflection extension, these are the X-rays which are more important.
Well, Scottish dog is explained in that oblique view, no, sir?
Yeah, it is in oblique view. Oblique view.
So,
Scotty dog, Scottish dog, Scotty dog.
oh, sorry, Scottish.
Scottish dog.
Scotty
Sir-
dog. The sign is called a Scotty dog sign.
So,
Scottish area, but it's a Scotty dog.
sir, actually, it is a bony thing. Like, so if other than X-ray for preoperative planning, CT and MRI both is needed, sir, or just MRI and X-ray? Just
MRI
MRI
suffice. There is no need for CT.
Yes, sir. So flexion and
Unless
extension.
it's a spondyloptosis in which you want to demarcate the exact thing, or the sacral dome is actually dysplastic. There is no need for CT.
So in one slide, you have explained about pelvic incidence and that sacral slope and all. Sir, that is little difficult one. Probably if you can explain it with that photograph. So
Yeah,
it will be easier.
I will show just this. Actually, I was worried that I won't be able to complete in time. So, yeah.
You finished well in time.
Yes.
Just a minute.
Yeah.
So pelvic incidence. So this is the sacral. Is my
Yes, sir. It is
so in this
visible.
picture.
Yeah.
Yeah.
Your arrow is
So in
visible,
this-
sir.
Yeah. Not able to see it. So the midpoint of the sacrum. Okay, you draw a perpendicular right to that sacrum. That point, the same midpoint of that thing, you have to connect to the midpoint of the femoral head. So in case the femoral head is not seen, you see center of the femoral head on both the sides. You draw a line, take a midpoint of that. So this
Yes.
point connected to the midpoint of the sacrum, and a perpendicular drawn to that particular point. From that particular point to the sacrum slope, to the sacrum, that is the pelvic incidence. Okay.
This is true lateral view, sir. Right, sir?
In the true lateral view. In a true lateral view. Okay. Now, the angle which the midpoint of the sacrum to the center of the femoral head, it makes to the vertical line. That is the pelvic tilt. Okay.
Yes.
And the sacrum, the angle the sacrum makes to the horizontal, that is a sacral slope. Okay. And in any spine, the pelvic incidence is something which is always constant. And the sum of pelvic tilt and the sacral slope is equal to the pelvic incidence. Is it clear?
Yes, sir. So in a stable spine, that pelvic incidence is equal to these two.
So if the spine, so if we see this, so if the pelvic tilt is less, as in the left picture, if the pelvic tilt is less in his listhesis, the sacral slope is very high, because that's the angle the sacrum makes with the horizontal. Okay, but if the pelvis is being balanced, the sacrum is being balanced over the central of femoral head, it's a balanced pelvis. The moment pelvic tilt increases, that means the sacrum is being pushed away from the vertical line drawn from the center of the femoral head. So the moment pelvic tilt increases, the chances of your sacrum being stabilized over the femur decreases, because the sacrum is way behind. So a higher PT is indicative of unbalanced spine.
Yes, sir. I think it is clear.
Okay.
हाँ sir. इसका sir importance.
इसका importance, if the thing is not being balanced, then you have to achieve as much as reduction as possible. And if still you're not able to achieve, and the upper vertebra you will have to include in your fixation level. Otherwise, if the entire construct is not being balanced over the femoral head, it's not a stable spine. So as long as your lower end of the spine is not being stable, your sagittal vertical axis is not going to pass just ahead of the sacrum. So it's always going to be anterior or posterior. So if it's more anterior, the chances of having a kyphosis at a level higher up above your fixation level will go on increasing. So the chances of patient, if there is an osteoporotic patient, that vertebra will go on collapsing.
So in one more slide, sir, you have showed the keyhole sign. So just in that one nerve root, sir, just so it because.
Yeah, it's very anterior. Yeah. So this is a T1 T1 SAG view, in which we see that just a minute. So can you make out at this where there is the vertebra where it is written L3?
L3, yes, sir. One arrow is near L4, sir, white color arrow.
Yeah.
That is quite clear.
So that white thing that you see along, so we are able to make out the vertebrae, the pedicle above, the disc at the level below. Okay, that
Yes.
white thing that you see is the fat sleeve, because this is a T1 sagittal image. Okay, and the black spot in that white thing, oblong thing that you see, is actually the nerve root. So the nerve root is surrounded by a fat pad, which is seen in the interpedicular space. That's the neural foramen. So this is how the normal thing should look like. Now check out a L5S1. L5S1, the fat pad is actually not being seen over here, and the black thing, the root is getting stretched. So this is the typical teardrop sign that we say, that the teardrop sign gets obliterated. So this is the fat, this is the root. Here, the root is being stretched over here. There's no fat. This disc is actually abating the root from below. So is the sacrum, which is actually pressing on the root from below. The pedicle and the pars, that's actually compressing the root from above. That's why the obliteration of the fat pad is seen. So a normal teardrop sign, which is like a tear, is obliterated at the lytic listhesis level. Am I clear?
Yes, sir. Please.
Sir.
Yeah.
Yes, Sachin.
Hello. Sir, spondylolisthesis is two type, mainly degenerative and lytic. Which nerve, sir, get compressed, transversing or existing nerve, sir? Can you explain?
So now, Sachin, this is alpha S1 listhesis. So which is this nerve root?
Sir, L5. Sir, this is
L5.
L5, sir.
L5. So for alpha S1 listhesis, the exiting root will get compressed. The exiting root is getting compressed because that's where the listhesis lies. So if there is central canal stenosis accompanying this, that's the time the traversing all the roots cauda equina will get compressed.
Okay.
Okay.
Yes, sir.
Yes,
Yes, sir.
Sir, just one more term, sir. You have used extension catch. Sir, what exercise we should in conservative treatment, sir? What all exercise we ask patient to do, and which
So
one?
extension catch is when you actually bend forward and you try to get up, there is a sudden pain which leads to a sudden jerk. That's called as extension catch, the catch while you're extending your body. So that's the extension catch. So what we should do, that's the next question you asked for exercises. So because there is instability, if you build up your core muscles, less likely that the slip will occur frequently. So all these core strengthening exercises you should advocate. Also, there is hamstring tightening over here. So we should stretch out the hamstrings.
So hamstring strengthening exercises we can.
Hamstrings stretching.
Hamstring stretching
And
exercise.
stretching of the hamstrings and strengthening of the core muscles.
So I think I've seen John sir used to write that abdominal muscle strengthening also
Yeah.
probably.
No, I think you.
So core muscles includes
Core muscles include the abdominal muscles.
so back extensors, abdominal core exercises includes all this core strengthening. So abdomen as well as back muscles. That's the core muscles.
Okay, and the it should not be like what we used to write in backyard exercise, that to do extension exercise. So here in spondylolisthesis, we should not do extension exercise, sir. Is that?
No. Back extensors and abdominal core, all these things has to be strengthened.
Okay,
So
And at the
extension
same time,
exercises, so the pain in listhesis is sometimes increased with extension. So you have to be careful of that. And not, it's not that you can't do extension, but some people, the pain gets aggravated in extension. So you won't do the classical extension exercises that you do for some of the spinal problems.
And one last question, sir, like whatever treatment you have explained, that is for fusion of this, means for stabilizing it's ideally it should be fused, that part which is getting listhesis, which is having listhesis. Is that okay, sir?
yeah, so the treatment option is actually stability, and stability comes with fusion. So only instrumentation is actually going to fail. So fusion is of utmost importance. We should spend enough time for having a good fusion bed, for giving good bone grafts, laying down good bone grafts in that space.
No more questions? Anyone, any from the DNB and candidates? Otherwise, thank you very much, Gautam. And
Thank you,
that
sir.
was an illuminating talk, but we need to have more questions from the candidates. I think that's important.
Yes.
Either they know it all or they are not paying enough attention, one of the two. Which one is it? So anyway, so thank you very much and bye till next time. We'll have another meeting next Tuesday. Okay, bye.
Yes, yes. Thanks, sir. Just
Thank
one
you.
thing, sir.
Thank you.
One
Yeah.
Question in message group. What are the clinical and management implication of spinopelvic sagittal balance in lumbar spondylolisthesis? Dr. AR has recently asked in DNB final exam. So management implication of spinopelvic sagittal balance. You have explained about pelvic incidence, sir. So spinopelvic sagittal balance is having.
That's what he was talking about. No?
Yeah, that was, yeah. So
you have to take into consideration the pelvic incidence, the spinal vertical axis, SVA, and even the L1 axis to S1. So all these 3 points I've enumerated in the slides. So the moment your sacrum is well stabilized, your L5, the lower vertebrae, the lowermost mobile vertebrae is more stabilized over the sacrum, and the sacrum is stabilized over the center of femoral head. your spine will be stable. If
Okay.
any of the parameters is not in falling into that expected guidelines, the patient is expected to have a toppling of the vertebrae. So the chances of failure, the chances of progression of the sleep will always be there. The process, the residual pain in post-operative period will be there. So there are papers in which the L1, S1 axis, if it was not less than 35, the patient had more of back pain. If the pelvic incidence was not restored, the patient had more back pain, and so is the sagittal vertical axis. So it's of utmost importance. In fact, pelvic incidence has been given importance not only in scoliosis, not only in listhesis, but in all the fusion cases that we do.
So I think, yeah, it's cleared properly the doubt. So there is no more question in the chat box, sir. So thank you very much, sir. It was great.
Yeah, so bye until next week. And,
Yes, sir.
you have the topic for next week?
So that ankle arthroscopy by Dr. Arvind, sir.
The on arthroscopy by Dr. Arvind.
Yes.
Okay, bye.